Hello. So in this video lecture, we'll be discussing the optional vaccines which are apart from National Immunization Program vaccines, that is National Immunization Schedule, which gives us the compulsory recommended vaccination for the children. These are in addition to that. So we'll quickly move on to the different types of vaccines which are given as optional vaccines. Influenza vaccines, they are available as live and inactivated. To use in India, we have inactivated vaccine which is produced from virus growth in embryonated hens eggs. So whole virus, split product and subunit surface antigen formulations are the different types which are available. Split products and subunit surface antigens are mostly used. Trivalent and quadrivalent vaccines are available for use in India. So the present year we do have quadrivalent vaccine which contains 15 mics of HA of each WHO recommended 2 influenza A strains and 2 of influenza B strains. So this is a particular vaccine available. So if you can see, this is tetra, that is quadrivalent vaccine. It's given as intramuscular in anterolateral aspect of the thigh or deltoid. For the children less than 3 years old, it is given as 0.25 ml, 1 or 2 doses. The second dose is given after 4 weeks. Between 3 to 8 years, it's given as 0.5 ml, again 1 or 2 doses. For children more than 9 years age, it's given as single dose, 0.5 ml. So generally, we do vaccinate every year, that is annual revaccination is recommended. Children who are not previously vaccinated, a second dose can be given after an interval of 4 weeks. So, not routinely all children are given this vaccine. Between 6 months to 5 years, we do recommend to prevent flu. However, children who are categorized as high-risk children more than 5 years, those who have chronic cardiac, lung, liver or renal diseases, hematological diseases, if they have diabetes type 1 DM and they are prone to have serious infections, congenital or acquired immunodeficiencies, especially HIV infection, primary immunodeficiency disorder, children who are on long-term salicylate therapy, children who are receiving chemotherapies during malignancies, and the laboratory personnel or primary healthcare, frontline healthcare workers who are at risk of developing influenza, we do administer this vaccine. So typhoid vaccine, again oral live and kill are available. We don't have oral live attenuated type. We do have parenteral formulation. VI polysaccharide and VI polysaccharide conjugated vaccines are available for use in India. So it's given as both the vaccines are given as 0.5 ml intramuscular route in anterolateral aspect of the thigh. For conjugated vaccine, we can administer below 2 years of age. The first dose can be given as early as 9 months, and the second booster can be given during the second year. For polysaccharide vaccine, generally it is given after 2 years because it's a T-cell independent vaccine. It's recommended throughout adolescent period if the child or the person is going to endemic area or at high risk place. Before going to a hostel, we do administer typhoid vaccine. These are the brands available in market. Hepatitis A vaccine, again it is a viral hepatitis A viral disease, can be deadly in pregnancy, it can be fatal. It is caused by hepatitis A virus. Live and kill are available. Live is not there in India as of now. It's under trial. Inactivated vaccine is available in India. It's a liquid. It is a liquid form. So given through intramuscular route, 0.5 ml as 2 doses. 1 dose is given at 12 months, the first dose, and second dose is at 6 to 18 months after the first dose. Generally, it is very efficacious. The 2 doses will give us more than 95% protection. There are no major adverse effects seen. So this is the available vaccine with us, that is 720 units. So catch-up vaccination can be done as 2 doses at least a few months apart to those who are not vaccinated before. For children who are coming for the first time after 10 years, we do first screen them with hepatitis A virus antibodies. If the seropositivity is present, we need not vaccinate them, or else we need to vaccinate as recommended. Varicella vaccine is a live attenuated vaccine developed from Japanese Oka strain. It contains around 1350 to 3000 PFU of strain. It's in lyophilized form. Need to be protected from the light. It is a live vaccine, so given subcutaneously in anterolateral aspect of the thigh, 0.5 ml. The first vaccine to be given at 15 to 18 months, second vaccine after 3 months, or at least before during 4 to 6 years before the child goes to the school. Even if the vaccine is given after 4 weeks, it is considered as valid. The vaccine efficacy after first dose may be between 70 to 90%. However, after the 2 doses, vaccine efficacy increases to more than 95%. So this is the available vaccine. Children may develop varicella-like rash after giving varicella vaccine. Pregnancy, immunocompromised individuals and HIV individuals where the CD4 count is less than 15%, severe anaphylaxis to previous dose are contraindications to giving this vaccine. Even if the child is vaccinated with varicella, sometimes they may develop varicella infection, that is called as breakthrough varicella. Generally, it happens between 2 to 5 years following the vaccination. It is mild disease, the skin lesions are less than 50 and fever may be very mild or there may not be fever. If it is there, it is of very short duration. However, it is contagious. Human papilloma virus vaccines are given in order to prevent the children from having cervical cancer in future. So there are different strains available in market. I have put the company names over there because these are the only 2 available as of now. We have tetravalent, that is Gardasil, and bivalent as Cervarix. Nanovalent is available, not marketed, not licensed in India. Minimum age is 9 years, which these vaccines are given only in females, girl children. Both of them follow a 3-dose series. 4-valent follows 026 and 2-valent as 016. 4-valent vaccine can also be given in males, but however, we are not giving. At the age of 13 through 45 years, all females can receive as catch-up schedule. The dose is as recommended for the routine intervals. So these are the few brands, couple of brands what we have for HPV. Japanese encephalitis can cause a deadly acute encephalitic syndrome by virus. So routinely the government has recommended this vaccine in some of the endemic districts, including both rural and urban areas. We have 3 vaccines, different types available with us: live attenuated, inactivated and virocell culture derived. So live attenuated vaccine, the minimum age of vaccination is 8 months. It is followed as 2-dose schedule. In fact, all the 3 vaccines are followed as 2-dose schedules. The first dose for live attenuated is at 9 months along with MR, and second dose is at around 16 to 18 months along with TPT booster. It's not available in private market. Inactivated vaccine is the minimum age is 1 year. There are 2 doses, 0.25 ml given at 0 and 28 days, given through IM for children less than 3 years, and for the children more than 3 years it is given as 0.5 ml, 2 doses. Inactivated virocell culture vaccine, again the minimum age is 1 year, 2-dose schedule. Here we do give 0.5 ml at 4 weeks interval. For both the inactivated cell culture and virocell culture derived vaccine, there is no booster recommended. Catch-up vaccinations are given for all the susceptible children up to 15 years when we expect a disease outbreak. Coming to meningococcal vaccine, it is available as polysaccharide or conjugated variety. There are 4 strains which are available, that is A, C, Y and W, that is quadrivalent. There is another bivalent which is A and C. It is given as 0.5 ml by subcut or IM route. It is recommended in children who are more than 2 years. Polysaccharide vaccine, as I already mentioned, it's T-cell independent. So meningococcal conjugated vaccines are available as similarly quadrivalent and monovalent serogroups. So it is given as 0.5 ml deep IM and revaccination every 3 years or 5 years in high-risk children and adolescents. So what are the indications? During disease outbreaks, a single dose is required. High-risk children, those who have congenital or acquired immunodeficiencies, terminal complement component deficiencies, functional or anatomic asplenia, including sickle cell disease, children with HIV or other immunodeficiencies, adjunct to chemoprophylaxis, those who are on chemotherapy, those who are going to Hajj pilgrims, travelers to the countries with African meningitic belt, we do need to give this vaccine. A single booster may be required between 15 to 55 years of age at continued risk of meningococcal disease if the prior vaccine was given at least 5 years before. Children, those who are immunocompromised and high risk group, 2-dose primary series of MCV administered 8 to 12 weeks apart for person aged 24 months to through 50 years. A booster dose every 5 years is required. Those who have received primary series before their 7th birthday, 1 booster in 3 years, subsequent every 5 years is followed. So these are the vaccines available with us. As I mentioned, it is tetravalent, that is group A, C, Y and W135 as polysaccharide. Coming to an important vaccine of rabies. So we all know that rabies bite can be very fatal. So when we have a rabies bite, we do categorize them as 1, 2, 3. The category 3, which includes single or multiple transdermal bites, contamination of the mucous membrane, exposure due to direct contact with bats, such are very, very deadly and will require appropriate wound care along with post-exposure prophylaxis with monoclonal antibody or human rabies immunoglobulin. Even the category 2, there is a small nibbling of the uncovered skin, minor scratches would also require post-exposure prophylaxis. So different types of rabies vaccines are available: cell culture and duck embryo vaccine. Post-exposure prophylaxis is given once the child has got a rabies bite, unknown bite. Here we give vaccine along with monoclonal antibody or rabies immunoglobulin. So the twin trap is a monoclonal antibody recommended to use in India. It's given as 40 units per kg body weight. The purified cell culture vaccine, a long-chick embryo vaccine or virocell vaccine, 1 ml or 0.5 ml are given in the schedule of 0, 3, 7 and 4th dose between 14 to 28 days. Here the 0 being the day of commencing vaccination, not the day of bite. The vaccine on 90th day, that is optional, is given for severe debility. Pre-exposure prophylaxis is given for given as 3 doses as vaccination intramuscularly in deltoid or anterolateral aspect of the thigh on day 7, 0, 7 and 28. So yellow fever vaccine is given for those who are traveling to countries where yellow fever is common, is prevalent. So it is a live attenuated vaccine given as 0.5 ml subcutaneously in the thigh or deltoid region. It's given as single dose, no booster doses are required. One certificate consisting of yellow fever vaccination is mandatory. That is taken at least 10 days before the travel. The adverse effects due to yellow fever can be because of immediate severe hypersensitivity or yellow fever vaccine associated neurological disease or viscerotropic disease. So these are the contraindications or precautions. We do not give yellow fever to less than 6 months, more than 60 years when there is HIV infection, during pregnancy and breastfeeding, and few of the contraindications as we mentioned for live vaccine do hold good for yellow fever vaccine as well. So those are the optional vaccines which I have covered with this video lecture. Thank you.